Hi.
Jayashree, are you there?
Hi, good evening.
Hello, Dr. Prem.
Hi, good evening.
Yeah. Can you just switch on your video?
Yeah,
Jayashree, are you there?
Hello.
Yeah, I can't hear you, Jayashree.
Hello, can you hear me?
Yeah. So, can I request you please to switch on your video?
Archana, I just wanted to check, is it audible? Is it?
Yes. So, good evening, Dr. Prem. How are you? You're on mute.
hi, fine. Good evening.
Okay, good. So, Jayashree, I will quickly update Dr. Prem on the meeting flow so that we can decide how to go about it. So what's going to happen is that first we will, while people are joining in, we will be doing an introduction
Okay.
of you as well as the support group meeting, and then we also have certain some competition which we had done some time ago. So we'll be just reading out the names. It'll be just basically to get the viewership coming in before we start the talk. Okay.
Sure.
And then Jayashree will take over, and she will set the tone for the meeting, and then you can start with your talk.
Okay.
What we will do is we have actually in this, if you have seen the agenda for the meeting, it is very specific: understanding and managing aggression and dementia. And actually in the registration form, we have asked people to share their challenges.
Okay. Okay.
So the questions will be quite specific, and I think Jayashree will moderate that and ask, and you both can do an interactive talk. And I'll also look at Facebook. I'll keep looking at Facebook and seeing what are the questions coming in, and I'll interrupt in between to just point you to those questions.
Sure.
So that's the way we have planned it. Do you have a presentation with you for today, or will you?
No, I don't have a presentation. I'm just doing a talk. That's
Okay, all right. So I think we already have quite a few people who are waiting. So I'm not, and I'll just. So you have shared with me your profile. I'll be reading that out. The profile you had shared with me earlier. So yeah, just give me 1 second. Hello. Thank you, Dr. Prem. So I'll start again. So good evening, everyone. I'm Archana Sharma. I'm the founder of Samvedna Senior Care. And we are ready to start our support group meeting. Today, we have with us Dr. Prem, and I'll be shortly sharing with you his area of expertise. While I do that, I just want to let our viewers know, if you have any friends or family who can't join the Zoom call for any reason, this program is also getting broadcast live on Facebook at our Facebook page, Samvedna Care. And you can just say Samvedna Care /live, and on Facebook you would be able to see that. As people are joining in, I just want to take a couple of minutes to talk about Samvedna. So we have been working with senior citizens for the last 7 years. We are a senior care company providing elder care services in Delhi NCR. Our services are multidisciplinary and include all aspects of aged care, including emotional well-being, as well as mental health, dementia care, of course, and any logistic supports elderly might need. So over the last many years, we have continuously worked on improving our Alzheimer care programs, and we have a variety of services to offer, not only the patient, but also the family, in terms of support for care, as well as understanding the issue dealing with caregiver stress, counseling, and different aspects of managing the patient's behavior. So today's agenda, as you all know, is understanding dementia and managing challenging behavior. And I have with me here Dr. N. Prem and my co-founder, Dr. Jayashree Dasgupta. So Dr. Nagnath has completed his MBBS from MGM Medical College, Aurangabad, and his MD in Geriatric Medicine from Amrita Institute of Medicine, Medical Sciences, Kochi. His senior residency was at the Department of Geriatric Medicine at AIIMS, Delhi, and he continued there as an assistant professor. He has an experience of more than 8 years in the field of geriatrics, and his major objective is to establish a strong framework for holistic elderly care through comprehensive multidisciplinary assessment and interdisciplinary interventions. He's passionate about teaching academics and research to provide the best evidence-based care for older persons. And his areas of interest include geriatric syndromes, dementia, urinary incontinence, orthogeriatrics, community geriatrics, and perioperative care of the elderly. He believes in establishing a continuum of care from hospital to home to the community, which is what Samvedna also works towards in terms of creating a multidisciplinary approach for care. And currently he is at the Department of Geriatric Medicine in Jaslok Hospital in South Mumbai. So we are honored to have you, sir, here. And we are very excited and look forward to understanding from you different aspects of dementia care. I also have with me Dr. Jayashree Dasgupta. She's my co-founder. She's a clinical psychologist from NIMHANS, and she's also a project director. So all the programs are spearheaded by her. She's directly involved in all the cases which we look at, all the issues which the families face. So over to you, Jayashree. I think in the interest of time, we'll get started. And I'll let you take over from here. At the end, I'll have certain announcements to make for the next support group meeting, which we can announce at the end of the meeting. You're on mute.
Apologies. So thank you very much, Archana, and thank you, Dr. Prem, for joining us today. And thanks also to all the caregivers and everyone who's joined us. And to begin with, Dr. Prem, would you like to just share a couple of your thoughts on this very specific area that we want to talk about today? Because this is something that we find a lot of our families struggle with. You know, how do you manage a patient who becomes aggressive? What do you do? What happens? Can you share some of your insights on this?
Yeah, sure. So thanks a lot for that lovely introduction. And of course, thanks a lot, Dr. Jayashree, as well. I would want to just delve into the topic straight away. And it's a very important topic purely because we all always feel that it's diagnosis, treatment. But what is important in dementia, I think most is caregiving. So a lot of issues that the caregiver actually faces is after we have done our work. So that is where we also need to support them. So as it's always said in geriatrics, that you need to take care of the patient behind the patient. So that's the caregiver. So sometimes it's an 80-year-old being taken care by a 75-year-old. So an 80-year-old can have a dementia, but a 75-year-old might not have dementia, but she might, or he might be the primary caregiver. And even younger people. So I would say we should always try to focus on that. And caregiver stress, I think, is one of the things which is very important in continuum of care as well. So today we have been very specific in dementia and aggression. So why does actually, aggression really happen as far as dementia is concerned? Now, it is very important that we as doctors and of course caregivers understand that. See, people with dementia can behave in certain ways which can be physically or verbally aggressive, and this can be very distressing not only to the person but also them supporting. So aggressive behavior could be very purely verbal, for example swearing, then screaming, shouting, making threats. It could be physical, for example hitting, pinching, maybe scratching, hair pulling, biting. So when all these things happens, obviously it leaves quite a bit of mental sort of trauma, even for the caregiver who's taking care, and of course for the person per se, depending on the level of dementia they actually have. It could be linked with the person's personality per se, and of course the behavior before they develop dementia as well. However, it's not necessary always. People who have never been aggressive can also end up actually being having this type of behavior, especially when they get dementia. So aggression, of course, is a number of behaviors, and it is often told as behaviors that challenge. So that's what we are talking about. Other behaviors could obviously be agitation, breathlessness, walking about, and a lot of other things, like sometimes even certain patients can be sexually inappropriate. Now, what causes this aggressive behavior? I mean, since before I delve into prevention and management, I would want to talk about how and what causes. So we need to understand that a person with dementia has same needs as any other person. They need to be comfortable. They need to be free from pain. They need to they need to interact as much as they can with other people. They need to feel engaged. They need to be stimulated. Of course, the level of stimulation is depending on an individual person, and they need to be basically be feeling well within themselves as well. Now, an aggressive behavior may be the person's way of actually trying to tell that no, they are wanting something but it has not been met, or they are trying to achieve something which is not being sort of looked after. So there are certain needs, as I was talking about. So the physical needs, purely the person might be in pain, maybe the person has an infection, there is a discomfort, it could be anything, it could be constipation. That's why we always talk about triggers. Whether they are thirsty, is it that they are actually been sitting for too long, is it that they have been lying for too long? Medications, I think medications are such important things as far as geriatrics is concerned, and even dementia is concerned. Maybe the medications are the ones which are making them confused and drowsy. So they want to communicate but they are not able to communicate, and ultimately they get irritated. Environment, I think environment is so important. For example, it may be too busy and overwhelming, too many people around, too hot, too cold, suddenly it becoming too noisy, suddenly becoming too dim, too bright, or sometimes nothing for that person to do, so there is no stimulation at all. So such things really matter. Then factors within, it's not only when we look at an older person who is having dementia also, we cannot only look at the dementia part. What about their poor eyesight? If they have a poor eyesight, hearing, it can directly lead to misunderstandings and misperceptions, like no, that particular person is actually talking about me, or they are actually saying things about me that I actually cannot remember. What do they think? So things like that can actually be very, very disturbing. Then of course the big component, the hallucinations part, now that becomes really, really when the person is actually seeing things which don't exist. Then delusions, where people strongly believe that things are actually not true, and from the perception of the patient or the person, you can imagine how confusing and frightening that is when the other person is saying no, these things don't exist. Then the person's dementia per se might have affected their judgment and control, and ultimately losing inhibition. So that can also sort of happen. These are physical needs. What about social needs? Purely the person the client might be just feeling lonely, not having much time spending, nobody spending time with them, maybe they're not feeling included. Secondly, they might just be bored, nothing to do to stimulate their senses, no tasty food, no nothing to stimulate hearing. Then maybe too many professionals in care, sometimes that can happen. Too many doctors, too many individuals, somebody is saying this, somebody is saying that, confusing the person. Then the person might not be entirely trusting that care professional. Now we have to understand one thing, thought processes are there in a person with dementia as well. We cannot just think that no, because there is a memory loss, there is nothing happen in the neural network. No, that is not. Another thing is sometimes when they are trying to hide things that they actually have. Initial part of dementia, initial part of cognitive impairment, they might just be trying to hide that no, they are actually not having memory loss, and then they cut off. So then socially they become more isolated. Psychological needs, we are all human beings. A person with dementia absolutely is. They have their right to be respected. Things like calling them demented, I mean, I shouldn't even utter it. I just hate that. Nobody should even call anybody that. It is always be cognitive impairment. And of course, when we brand them as dementia, yes, dementia. Why? Because there is still a stigma. Everybody might, a lot of people might say no after diagnosis, a lot of things are there. No, but there is still a stigma. Oh, they have, वो मतलब बिल्कुल ही याद नहीं रहता उनको, and things like that. Misconceptions, memory difficulties are there in processing information. So that might be the issue. For example, they might feel that they were doing a lot of things before, but they're not doing anything more. They might be just frustrated and not able to do tasks which they used to do very easily, like making a cup of tea. I mean, you can imagine those things where imagine a homemaker who actually loved cooking suddenly has got cognitive impairment and is not able to do that. So that frustration can be there. Depression can be there with dementia. It's always thought no, depression and dementia are completely either I mean, sister diagnosis. No, they can be together as well. Then misunderstand the intentions of the person. For example, personal care can also be threatening to an older person with dementia. Remember, people might think that no, they are actually crossing their boundaries of personal space. For example, washing, dressing, going to toilet. See, ultimately they also have their rights, they also have their things. So that particular mental aspect might be actually affecting them. Then many people just feel that people with dementia cannot actually make decisions. So it's like no, unko yaad nahi rehta, so we'll take decisions. So direct ignorance. So then these people who are actually having cognitive impairment get irritated. Arey, why I have not, it's a decision about me, why are you not asking me? Then threatened by a environment that appears to cause them stress. Too many strangers, maybe suddenly 2 or 3 people are there they're not very comfortable with. That's why it's always said when we have professional caregivers, we always want to build a good rapport, and then only we try to continue with the same. I mean, for us who provide caregiving might feel that they are good caregivers, but for the patient it might not be that particular thing. Then difficulty in understanding the and working around the world around them. Now that itself is so different. For them, the reality might be different. For example, they might be recollecting, no, I have to actually collect children from school, because that is the thought process that they're actually. But then they become aggressive and you're not allowing me. I want to go and pick up my grandchildren. Just because you think that I cannot remember doesn't mean I cannot go. So such things actually sort of affect them as well. Then how do we respond to this aggressive behavior is very, very important, because reaction, sometimes this might happen suddenly. So we don't have time to actually sort of respond immediately. So what do? Before you react, always take a deep breath. Remember that, step back, give the person time, space. It may help if you want to leave the room, but until unless you're feeling calmer, although it can be very difficult if somebody gets aggressive, an angry response will never help. To be very frank, an angry response to any situation doesn't help. So make sure then you're safe. You should never tolerate violence against you. Make sure that you obviously do not end up hurting the person, because sometimes defense itself can be hurting the other person. Now, if the person's behavior is, of course, physically violent, try not to show any fear, alarm, anxiety, because sometimes what happens is that itself might increase the person's agitation. So just walk away from the situation or try to call for help. Do not try to restrain someone or try to get too close, too threatening, because that might not help. Do not try to shout. Do not try to initiate physical contact. Again, this might be perceived as the person as threatening behavior. Try to reassure the person, acknowledge their feelings, say, "Nahi, I know you're angry. Relax. I know you want to look after the children, you wanted to pick them up, but they are safe. So don't worry. Everything is okay." Then again, unfortunately, not always it can be done, but please do not take any of that behavior personally. The person might be actually probably just trying to communicate a need that something is wrong, and they are not trying to attack you personally. Just listen to what they are saying. Try to keep your body language open, uh, and calm. Just relax. Try to keep eye contact. Encourage the person to communicate with you, and try to distract the person attention if they continue to be angry. And if you're there to support for a particular activity or a task, just hold back a bit and then help them to do the task after they feel calmer. Now, when the behavior has passed, please, of course, nobody will do that, but there should not be any blame or trying to be aggressive regarding the behavior. No, you behaved like this or that. Focus on the person, not the behavior. They might still be upset and distressed even after the behavior is actually passed. So you would want to still keep them calm. Another important thing is, please take some time and talk about your feelings with others. It could be anything. It could be friends, family, it could be the doctor, it could be the counselor, it could be support groups. Because if you don't talk about what you feel, it might actually be harder to care about that person, because you're not being able to discuss it. You're not being able to uh, uh, discuss and try to take steps. So what would happen is, you will end up focusing on the behavior and thinking about it rather than actually thinking about the person. Then again, the crux: how would you prevent and manage such aggressive behavior? It's always important that we make your caring role easier. So working out around the aggressive behavior will obviously make you to get an easier way to find a solution. Now, treat the person as an individual. Most importantly, forget the behavior and see why they might be actually be behaving that way. Try to see what is happening from their point of view, identify the reason, and then we try to take steps. Now, the first step would be identify the problem. Is the behavior of that particular person with dementia causing the problem? One. Is it a reaction or attitudes of other people? Is it the person's living situation? Whether they are living alone, you just care, you just come in between and visit. Are there any factors, for example, pain, constipation? Is there too much stimulation? Is there less stimulation? Is the environment actually suitable? Then look at the situation. Just track back and see when and where the problem actually happened. Does the person always behave the same way or act the same way in that particular place? Does it always happen with the same person or in similar circumstances? Then who are the other people involved? For example, does it happen when there are visitors? Does it happen when there is a family member? Does it happen when there is a friend? Or does it happen when there is absolute strangers? Then we need to try to look for patterns in the behavior. It may be helpful that you actually make a diary and see that where the aggressive behavior is, noting down what was going on that time, what could have actually triggered the behavior. So it's quite a bit of homework wherein we actually have to see that what might have actually triggered the behavior, because we need to manage the behavior. In fact, most importantly, we need to try to prevent it happening again. Then we have to look at how the person is feeling when they behave very, very aggressively. Is the person unwell, in pain, uncomfortable, tired, overtired, scared, anxious? Do you feel the person is frustrated, embarrassed, misunderstood, feeling really ignored? Do you feel that there is any kind of delusions? Are they expressing that they're seeing somebody like hallucinations? Are they depressed? Do you find them bored, understimulated, not having any kind of social contact at all? Do you feel that there is actually a suitable environment or not? So these sort of things you need to see. Next is identify anything that the person could be reacting to. Is it an unpleasant condition or an incident or an association that they are correlating? Is there a change? For example, a sudden change in a caregiver, sudden change in the type of food, sudden change in doing some other things? Are there any personal likes, dislikes, fears which have actually instigated it? Is it a memory which has actually come back to them, or it is the one which is patronizing them, thinking, oh my God, this is what has happened and this is what has triggered everything? Then are they being provoked? Or is there a conflict with someone's personality, somebody who's actually sort of maybe taking care of them or coming to meet them, or somebody they have been exposed to? So what we need to do obviously is to develop a strategy to manage the behavior. So one is, of course, how coherent and how comprehensible they are. Talk to the person with dementia and other people who they spend time with, and then try to come up with a plan. Now, sometimes it is basically trying to titrate, try different things. For example, changing the way you talk to the person will help. Then, as far as altering the environment, try to focus on what their best interests are and supports them best. Then, you might as well want to see if there is any pain and what kind of things you need to do if there is pain or discomfort. If there is a pain when trying to rub or pulling at a particular body object, then see facial expressions. Are they looking scared, trying to clench their teeth? Body language, do they feel a bit fearful? Are they a bit rocked up? Are they huddled? Are they actually a bit reserved? Then do they have a change in appetite? Are they being more restless than before? Of course, any new swellings or inflammations, because even any kind of infection and a fever, any kind of infection can also sort of trigger pain, and that can also sort of trigger aggression. So when a person is in pain, we obviously try to rule out things like if there are any infections like chest infections, urinary infections, then any cuts and bruises, then any constipation, very important. If they have had not passed stools, it can be so irritating to a normal individual, a person with dementia even more so. Existing conditions like arthritis, if they already are taking medications for the same, have they missed their medications? So arthritis can be an issue. Then maybe being in an uncomfortable position or being moved in an uncomfortable way. Always we need to, as caregivers and as professional caretakers who are taking care, respect the fact that they also have their rights, they also have their dignity. So no uncomfortable positions or no uncomfortable way they should be moved in. Then toenails and fingernails that needs cutting, very small things, but these can be very irritating and can be causing a lot of pain. Then toothache. Now, toothache is something they might not always be able to express, but when we see that, particularly maybe is it while eating or is it while other things, that they're actually trying to express the same. Earache, another important thing, and problems with dentures. That's why we always tell all elder people, whoever visit us, to bring their dentures, because even sometimes dentures are there. Whether dentures are actually causing more ulcerations, causing more pain, can be the issue. So that is something also we need to take into consideration. Hearing and eyesight. These two are another things which are very important. If they need hearing aids, they should be provided with. If they need to get glasses, they are any other individual. If their sensory systems are affected, it will only increase the aggression and their irritation. Now, what are other ways to manage aggressive behavior? Of course, there's always non-pharmacological and there is pharmacological. So I would like to dwell on some non-pharmacological tips first. When most important with a person with dementia is communication, I feel. So body language should be good. You can't be too fast. You can't be too slow. The tone has to be very important. You can't be too loud. Uh, you have to sort of think if they are if you are going to be if they are going to be struggle to communicate. Make sure you're in a good place to communicate. You should be quiet and sort of quite calm. Not having some TV, radio in the background. Busy environments don't help in communication. And plan enough time to spend with the person. If you're rushed, then that can affect your communication and that can lead to aggression. Then talk about conversations with they will be sort of interested in. Don't confuse them with too many things. Then make the most of good days. Try to talk more about that. Get the person's full attention to start with, rather than you be just trying to talk something and they're not attentive and then they're just getting irritated. Then another, of course, is music. Now, music can help in reducing aggressive behavior. It may be listening to their favorite piece of music, enjoying music in groups, or music therapy, which is, of course, with a trained professional. For example, a certain part of the day, the person tends to get aggressive. You can see by trying to put some music, whether they enjoy it at that time or not. Now, music can also work the other way. For example, if music is too stimulating, then that might increase aggression. So we need to be very careful on what type of music we are actually doing, something that they like in the past. Then social interaction and stimulation. Now, a lot of older adults with dementia can actually be bored, isolated, unhappy. So sometimes you need to give them that one-on-one interaction. It could be just a chat, it could be just reading something together, and trying to plan new activities which they will enjoy, and adapting daily tasks so that they can still in some way try to take part in them. And sometimes it's like a titration hit and trial method, where if you think that something works well, then keep doing it, because that is something we need to sort of always try to focus on. Then reminiscence is very important. Life story, recalling very famous things in the past, talking about past experiences, sharing of photos, then positive experiences, of course, like a family event, maybe a favorite moment, places that they have visited. Then things like you can have a memory box of photos, albums, and then you can all develop maybe a life story book. I mean, that is one way of actually trying to go through all the experiences. They might have positive and negative ones, but try to focus on the positive ones so that reminiscing actually becomes uh, very enjoyable. Then changes to the environment, try to make it a better environment, see if it's is there enough light, is it too hot or too cold. Can a person with dementia actually find the toilet? Now, if finding the toilet is a problem, the path to the toilet should never have obstacles. Always that path to the toilet, I mean, at least the distance should not be much, because of course the other syndrome can then play in urinary incontinence, and all last thing we need is a fall while going to the toilet as well. And it should be clearly visible, the path wherein they actually have to go. Then try to use signs on kitchen boards, drawers. Of course, in severe dementia, we would not want them to do anything on their own, but if they are still sort of able to do to an extent the activities of daily living, then we should encourage them to do so. Then physical exercise and activity can of course help in reducing aggression to an extent. For example, it can help in being a distraction, and it provides you opportunities to have social interactions in others. So for example, if a group exercise can be done. Then other therapies which can be obviously seen is hand massage, just relaxing them, aromatherapy, then stimulating the senses, for example, certain sounds, repetitive actions. Then specific, of course, cognitive stimulation, that is activities and exercises which will improve memory and communication skills. Then activities on day-to-day basis. Then pet therapy, animal assisted therapy has been used and it has actually helped as well. Arts therapy, I mean, some of people with cognitive impairment do some brilliant arts, drawing, painting, which I have seen myself personally. So I think that is something also which helps them and also takes out hidden talents which we might not have actually known about. Then drug treatments, yes. If the behavior becomes too challenging, aggression is too much, then we might actually have to look at drugs, especially antipsychotics. As a geriatrician, have to be very careful that it should not add to the person's confusion, because that would be a back step. Antipsychotics, again, we usually try drugs if the behavior is actually going to put themselves or any other person around them at risk. If not, then we try to hold back the drugs, purely because any drug has interactions, and in a person who's going to be thin line, like a person with dementia who might actually have other comorbidities and have drugs as well, the interaction might land up in a soup. Then some antipsychotics help, and they help in decreasing the aggressive behavior, but it's nothing happens very soon, so it might actually take around 6 to 12 weeks as well. But a lot of antipsychotics can have side effects, so we obviously are averse to that. But again, let me repeat, if it is self-harm or harm to the person who's taking care, which could be you or the professional caregiver, we have to be very, very vigilant in trying to calm them down, because that might be needed. So if the symptoms which might have to be taken care of might be delusions, hallucinations, and of course the aggressive behavior. And as I said, we always try to manage things in a non-pharmacological way first. And then, of course, we would want to also include drugs. So this, of course, was an overview, I would say, on aggressive behavior in dementia, and also how we can prevent and manage it. I would like to just, I mean, if you have to just put it in a nutshell, it's basically, I wouldn't say that there is a set pattern. There cannot be, because every older person itself is different. The word is heterogeneous. It might look like a complicated word. The word means no older person is actually similar. So everybody is different. One, add on to that memory impairment. And let me be very frank, nobody gets only that. Sometimes you have memory impairment, diabetes, hypertension, with urinary incontinence, a history of fall. I mean, a lot of things. So try to work out your plan as a caregiver. Something that might work for another caregiver might not necessarily work for you, but support groups like these are very important. Support groups for caregivers are very important. My final thing would be, remember, you also are a human being. You need to take care of yourself, purely because you need to take care of somebody with an illness. And I'm not saying only dementia, let me be, I mean, a variety of illnesses. So if you stay fit, that is when you will be able to take care of them. Do not be hard on yourself, because ultimately you need to have the me time. By me time, it could be 5 minutes, it could be half an hour. How much? You don't even do anything. Just close your eyes. Just envision yourself where you could be in a place of meditation, where you feel that it is your time, so that you relax and then you get back to it. Never shy away from having support. Taking support doesn't make you weaker. Taking support actually makes you stronger, and you might be able to take care of them better. So that is something I would want to quote before I conclude. So thanks a lot for your patient hearing. Thank you.
Thanks a lot, Dr. Prem, for that really comprehensive overview of, all the, I think you've covered most of the challenges that caregivers face, right from, the frustration that they face with really struggling to understand what's going on and why, a person may be aggressive. I mean, all the trigger points. You really emphasized a lot on trying to understand what the patient's needs are. And how the environment contributes to it. You spoke a lot about just the lack of stimulation. We have a lot of patients who we see over the course of time. We see a change in their behavior because they start to look forward to the time that the specialists spend with them. So stimulation is something that I think is we don't give enough emphasis to. As pain, which is something, again, that becomes very difficult sometimes to just even diagnose, because you've met, as you highlighted, communication, the patient's ability to really just communicate as we would when we're feeling pain gets impacted. And you highlighted several things that the caregivers themselves go through in terms of challenges about really taking that first step to seek support, whether it be from professionals, peers, anyone else, to try and understand what they can also do to deal with the problem. So thanks a lot for that really great overview. We've already received a lot of questions from people who've joined us today in advance. And I would request you all to share any questions that you have in the chat window. Just to let you know that this is being recorded, and we will be putting this up on our social media channel so that others can also view this later. So if you would like to ask a question, you can feel free to do so in the chat box, or you can send your questions to the host, and we will put them across to Dr. Prem anonymously. So please do type in your questions. But just diving straight into some of the things that people have already asked us about. One of the questions that we've gotten, we hear this a lot, is really, how does a person understand whether the person is actually able to feel anymore? A question that we have from people a lot is in advanced stage of dementia, is this person really able to experience pain? Because they can't remember anything, they don't know what's happening around them. Are they even experiencing pain? What is, can you help people who've joined us understand that a bit better?
See, as far as that is concerned, I would say it's not that easy, purely because in an advanced stage of dementia, we are looking at a person who might, I mean, purely from a caregiver's perspective, might not acknowledge anything. I mean, even the fact that they've been caregiven for or they've been cared for. But I think what we need to do is see the subtle signs, which we always tend to do. Like, I mean, you can see that they've actually not passed stools. So if they have not passed stools for one day itself is constipation. But as you get older, it can be 2 to 3 days. A lot of older people might go once in 3 days also. So that's not abnormal. So that is a trigger of pain. Then if they're not passing urine, a lot of times the bladder actually becomes really up and they keep trying to get agitated. They might not say that it's actually the urine which is a problem, but then you are like, they have not passed urine. So these subtle things, I wouldn't say it's not entirely right to say that they don't feel pain. The expression of pain is different. So that is something which we need to sort of see subtly. And another thing, as you were saying, is pertaining to pain and otherwise, is most important when you're trying to take care of a person with dementia is try to understand the disease. Because it's not the person who's changed, it's the disease that has got to the person and then things that have happened. But at the same time, let us not ignore that part. So as a caregiver, you should not ignore that they actually have dementia. Try to treat them in a very similar way, but in a specific way. And as far as the pain paradigm is concerned, as I told you, even bed sores. I mean, bed sores are something who are bedridden and you will not know it. It will never glare out. There is nothing to even show it. But when you actually do caregiving, that is when you realize, oh my God, there is actually a small thing. And there have been patients, of course, the caregiving was poor. So at that time, there have been bed sores and that itself causes infection and we discover it and then we treat that and it's okay. So ultimately we need to sort of see it subtle signs which can sort of be painful. Then of course, if they have injuries, as I told you, injuries, bruises, I mean, any person will be having pain. So it's not necessary that they will not be expressing it in the same way. So I would say, as I reiterating the same thing, aggression, I mean, the way of expression might be different, but it doesn't mean that they don't feel pain. So that is something which we should be always careful about. Another thing which is very easy to do is to sedate them, which is not something that I really believe in, because it just becomes a sort of a shortcut. I wouldn't say always, sometimes you need to, but what happens is with the drug, as I told you, some side effects can happen and then you regret doing that also. So that is also something which you should be very careful with.
Right, absolutely. And I just wanted to, another thing that we're often asked is, we see a lot of disinhibitory behavior, inappropriate sexual behavior, and people don't want to talk about that. But this sometimes could also be related to experience of, like pain, urinary tract infection. Can you just highlight a bit more about the linkages, if any, between these things?
Absolutely. Just to highlight that, I would say that, as I told you about, they might actually have chest infection and urinary infection. So what happens is there is, of course, something known as delirium. So delirium means an acute confusional state. So an older adult is already susceptible to having delirium. For example, if a younger person gets a pneumonia, they would come with chest pain, cough, breathlessness, and that's usual. So you will take them to the doctor. But an older person might just come in altered behavior. That's it. Imagine an older person with cognitive impairment actually having a pneumonia. So that behavior gets superseded. So they might actually get aggression. So things like sodium being less, which is known as hyponatremia, electrolytes, then chest infection, then urinary infection. These are all things which can actually be pertaining to acute confusional state, which is worsening the dementia. So a person who is at the risk of dementia, at the risk of having dementia, is always at the risk of delirium. That's why we say, as a caregiver and as a doctor taking care of older people, we draw the line that if something happens, we are going to take care at home. because a lot of times ICUs, hospitals are not ideal places for people with severe dementia. Imagine they are just seeing lights, they are just seeing people with masks. This is all overstimulation, this is all over aggression. So that really doesn't help them mentally in any ways. So we try to tackle these things at home. So I would say that always feel that there are things which can be reversed. Infections can be treated, pain can be treated. So that makes their life better, and indirectly it obviously gives you that content that you have been able to take care of them and at least relieved some part of it, if not everything.
Right. Absolutely. And I request you to also share your questions. Either you can send them in directly in the chat window, or just share them directly with us. Another question that we have is, challenges around feeding, which often leads to, a lot of agitation, feeding and
Absolutely.
bathing. How can a caregiver manage these better?
As far as I think feeding is concerned, you have to be very precise. One, by precision, I mean you can't confuse an older person with dementia. You can't have a thali. Let me be very frank. Multiple components is absolute confusion. So you need to give them maybe a single. For example, it's a katori of dal. For example, it's a katori of rice with dal. So things that they actually see only singularly. So they will be like, okay, then they don't get confused. That is one way of doing it. Second is trying. There have been times where people eat with them. So when they eat, they try to just imitate. So it becomes like a mirror thing, and they also eat with you. Now and let me be very frank, it's hit and trial. I wouldn't say that this would always work. Then sudden propensity of eating a lot of sweets. So that also happens. If the person is not diabetic, I would say that there is no restriction whatsoever. So sometimes you trying to do it and then they would try to do it. That is a good way. Then a lot of them might prefer solace while they're eating. So for example, they don't want to be disturbed. So if you are sitting in front of them, looking at them, whether you're eating or not, no, that is not something
That
that
can
they
be
want.
very annoying for anyone.
Yeah. I mean, to be very frank, that can be as if you have been monitoring. Okay, you're not eating, you're not eating, you're not eating, you're not eating. I mean, that's what is happening in the mind of a caregiver. Is the person
And
going to eat
especially
today?
this is a person who is capable of doing these things
Yeah.
earlier, and
So
now
then,
suddenly they're being monitored for something as basic as this.
and I think that's what hits them also. We never realize the psychology of a person who actually is on the borderline. I would say just getting into the cognitive impairment, and they're like, oh my God, I could do this earlier. So why the monitoring now? Let me just eat at peace. So that might be. Sometimes you have to sit, but try to see whether they are being independent. As I also told you, tactics of doing it, try to assist them in the task, not necessarily do everything yourself.
So the
I
way in
don't
which
think
you
everybody
communicate and encourage.
exactly. I don't think they want their independence to be lost. Not always. Maybe I'm not talking about severe dementia wherein people cannot, they will not be able to feed themselves. So you're just trying to feed them itself this is just irritating. They might be just express it by an aggression. So this is another way of sort of doing. Then things that they liked. I mean, for example, if they like the pav bhaji or a chaat or whatever, at some point of time, try to give that. It might work one day, it might not work the other day. That can be frustrating as a caregiver, but that is where the patience comes in, because unfortunately you have to be patient in that. Then the bathing part. Now the bathing part a lot of times can be intrusion into personal space. Is it that they are feeling? No way of expression, but they might just be shunning you off. What is this? So if they're still independent in trying to take care of, maybe even trying to put two mugs also, and that works for them, try to do that. Because ultimately that self respect, that right of actually having dignity is never lost. So that's why I say, let me be very frank, even if an older person with dementia, without dementia, any age group, we always tend to, we cannot take it for granted, no, that they are not wearing the clothes, or even the pant is just a bit. No, the dignity has to be maintained till death. That's why if we see, that's why we cover the body also. We come the way we go, but we always cover the body. So the dignity has to be given even for a person with dementia. And again, as they say, you have to be flexible. For example, agar is time mein they are not cooperating, so see, maybe during the night time, are they trying to cooperate for taking bath, or is it early morning, or is it specifically hot water? or is it specifically cold water? So just try to backtrack. As I told you, you might have to put up in a diary, and then you might actually have to do it that way. Then another issue happens with professional caregivers, wherein people come in and they just don't cooperate. They just try to hit them. They are like they get aggressive. So if you feel that it's not working with that, you might actually have to change them. Then it doesn't happen always, but then there have been cases of abuse as well. So we need to see those signs as well as a caregiver, whether any sort of abuse, whether it's physical, whether it's emotional, is actually happening, because they are very susceptible to it, because they might not retort. So that is also something as a caregiver. I'm not saying be worried about it always, but if you see certain changes, just keep it in mind. Is that the reason they are just saying that don't touch me at all? So that is something you need to keep into perspective.
And this is actually, I think you've already touched upon some of the other questions that we had around whether a person is able to really understand what is happening around them when they're being dressed or bathed, because it's clearly, it's important for caregivers to keep in mind the dignity of the person. And again, I think you've already highlighted, as with feeding, this constant reminders or monitoring them is something that they're not used to. So we've got a question about, how do you deal with this role reversal as a caregiver? This is somebody who's, your parents or your spouse is someone who's been a source of support and strength up until this time. You see a deterioration in their cognitive abilities, and then gradually there's a role reversal, and you become a caregiver. You're almost taking care of a person who's taken care of you up until this time. How does a caregiver deal with that challenge?
So I think the most important thing I would say is ultimately when that thing happens, let's be frank, it's not easy. So don't be under the impression that it's easy. It's not easy for anybody. And people who we draw strength from, especially our parents, it could be anybody who's actually getting into that, to see them slightly wither away like that is not easy. It's never easy, because you have cared for them, they have cared for you. But ultimately we need to know that there will be a limitation, but we should do our best. So we should do that. Should not happen to the extent, there should not be any guilt. Let me be very frank, a guilt of that, whether I have done enough or should I do more. Sometimes what happens is it's just overdone. It's not because you want to overdo it, it's just that you care about them so much that you might be overdoing things, and that might actually be worsening things. Try to give them also a personal space as far as the person with dementia is concerned. By personal space, I mean you can't be 24 hours be there for them. A day has 24 hours. You also need to sleep. You also need to do other things. Let us be very frank. It's not that full-time caregivers, you are not full-time caregivers always. Maybe you are actually working. You are the ones who's actually getting the so-called financial aspect also to the caregiving. So you need to concentrate on that. And then you have other people, maybe professionals, maybe friends, maybe neighbors, whoever, who's actually trying to help you tide over that particular time. So for your mental peace also, it is very difficult that when you are at your place of work, you're not thinking what's happening at home. Purely because then it doesn't work, because you are not able to focus on what job you are doing, and at the same time you are not happy about what's happening at home. So try to take that, I would say try to take it day by day. Let me be frank, you can't predict, because one day, as you're seeing, and sometimes the feeling that most caregivers have is that it's actually happening in front of my eyes and I can't do anything about it. Don't think that way. You are doing everything about it. You are doing everything possible. The drug cabinet is what I quoted for dementia has been barren for quite years. There have been not a lot of new drugs which have actually come. That's why we keep talking about prevention. Another learning that you need to have, if somebody actually you are being caregiving for that particular person with dementia, if you're a caregiver, try to inculcate in younger people that they need to take care of themselves for the reversible causes from before, because it's prevention that matters.
Can you highlight some of the risk factors? Because we have another question on that.
Yeah.
What are some of the risk factors for dementia?
I would say the biggest part about dementia is it's always reversible as well. So there are causes of reversible dementia and non-reversible dementia. I mean, irreversible. Now we keep the thing is it's not always highlighted that it's the irreversible dementias which come out. It's because they are so glaring. Alzheimer's, frontotemporal dementia, dementia with Lewy bodies, because there are so many behavioral components. People literally, there is wandering. So it becomes such a shocking thing, and the behaviors affect us so much as caregivers that we only think that. Why I'm saying is most elders who starts forgetting, they're like, "Arey, I have got Alzheimer's." No, there are reversible causes. So what are the risk factors? If you have diabetes, if you have hypertension, if you have coronary artery disease, that is heart disease, if you have had a history of stroke, then you're at a risk of vascular dementia. So vascular dementia is something which can be taken care of by taking care of the risk factors. So these are the risk factors. Then there is something known as hypothyroidism. Your thyroid is low. That can also cause cognitive impairment. You correct your thyroid, your cognition will be better. Vitamin B12 deficiency, folic acid deficiency, these are two vitamins. If they get deficient, then that also can lead to a reversible dementia. Falls. Why I'm saying is there have been a lot of cases where an elder has fallen, and slowly and steadily we have realized that the memory is going down, only to discover that when we do a brain imaging that there is a nice collection of blood, which is known as a subdural hematoma. All you need to do is take it out. So sometimes we keep thinking that, oh, this memory loss may be because of aging, or this memory loss is because this person has got Alzheimer's or something. That's why I say try to seek help immediately when you actually have doubts, because
And
you as a caregiver, yeah,
and this
and
may
you as
actually be a sudden cause of agitation, a sudden change in the
absolutely,
behavior.
absolutely, because sudden change. So you have to see, because I'm not saying people brand it. Somehow we just brand it to an ageism. Arey nahi, old age mein ho jata hai. And not old or younger people, old people themselves do it a lot of times. No, we are 65, we are 70, we are 80, it must be a part of aging. No, it's not necessary. Dementia is not aging. There is something known as age related, a bit of, you can say, senile cognitive impairment, but things come back to you. You won't forget, you won't wander off, you won't, not every day will be new. So these are the and risk factors. And how do you tackle it? There is no age for starting exercise, there is no age for learning. I mean, learning, older adults have taught me, I would say, taught me a lesson, not in a bad way, in a good way, that in this pandemic, they have told me they can actually learn technology and do anything.
Absolutely,
And that has been
absolutely.
the biggest silver lining. The
Yeah,
fact that we are doing support groups here with a lot of older people and their caregivers is the biggest silver lining. So
yeah.
try to learn, try to have those memory aids,
Hmm.
and try to take care of risk factors: diet, exercise, and taking care of those extracurricular activities. For example, smoking, drinking, all these things have no age to stop or reduce. So these things are which we should control. What is in our hand once, because dementia is set in, we are looking at a plateau. We either want it to continue that way and hope it doesn't worsen, because we know for a fact that there is nothing which has been created to actually completely reverse it yet. Maybe someday there will be. There is a lot of anti-aging which has been worked on, but it is all prevention, earlier. It is not after everything happens.
Absolutely. Yeah. Yeah. No, thank you for sharing this capsule on the things that we can actually do to, deal with modifiable risk factors for dementia, and highlighting, you know, uh, this so well. I think there's a number of questions that, people who have joined us have. So, Archana, maybe I could go over to you and ask you to share those questions.
Yeah, definitely. I thought you were able to see them. So I'll just read out because they've been sent to me privately. So there's a question around aggression, that sometimes the aggression follows a pattern like every alternate day. In our case, my father gets anxious and aggressive over food and medicines, of which we have to be given at a certain fixed time. So this is the challenge this family is facing.
Okay, so you might actually have to make it maybe a bit erratic. I mean, the reason I'm saying is maybe the fixed time is the one which is actually irritating him. And let me be frank, drugs and food are two biggest challenges that all caregivers have, especially of people with dementia. So you have to be tactful. Sometimes, a lot of times, you have to actually put it in the food. A lot of times you might, I mean, especially the crushable ones, of course, if they actually have to be taken with water, then it becomes difficult. Then if food is also an issue, and if it is actually happening or alternate days, then try to see whether which part of the day, whether there are some trigger factors during that particular time. uh, Try to see if you can change the environment at that particular time, maybe just shift the timing a bit more ahead or a bit more later. Such titrations will actually help, purely because you are dealing with somebody. Or is it happening, oh my god, oh my god, now the food is coming, now the food is coming, I am not going to eat. So is it that go is so is that a fixed pattern which is actually happening for the person from within? So that is something we need to shuffle around, so that we can sort of move around it and try to address it.
Okay. There's another question around Lewy body dementia, and she's saying that her mother feels very, very hungry all the time. Even after having full meals, she wants to eat again. And how do you handle that? And she's on a walker and can't walk on her own, so has gained a lot of weight.
Okay. uh, it's a tough one, to be very frank. The reason being that I have also seen a lot of caregivers saying that, I mean, it's a total cleanup. It's like khana ho gaya hai, food is done, but I want again. Arey, you have not given me food. What is this? You want to starve me, or you want to? What are you trying to kill me by not giving food? It becomes very difficult. So I would say is try to monitor the amount of food. Try to give lesser, smaller portions every time. You can say try. I wouldn't say bribe. Bribe might not be the right word. Try to say that ki, I'm going to give this now, and then later maybe change it into something. I'll give you more quantity later. So things like that. Or else I can understand what's happening is because if she's a dependent person who actually has a walker, so the next thing that might happen, if there is too much of weight increase, she might stop using the walker. And then if you're looking at an impending bedridden person, then it becomes difficult with dementia. So that is what you might actually have to do. I am not even talking about any kind of exercise or anything, because that's not going to happen, because you're not going to be able to force them to do it. So try to give her things which are maybe low calorie but tasteful, so that at least you are able to take care of the taste part, but at the same time you know that at least the weight gain will not be that much. Healthy stuff like nuts and fruits. I mean, fruits are never, to be very frank, don't add much to sort of the weight as well. A lot of people don't like juices. I mean, it's titrate again, because juices tend to spoil the taste, according to a lot of people, because it's not a actual fruit. So you might actually have to give the fruit. So it's all titration. Try to change it that way. Try to give tasty foods but maybe lower calories, so that at least the weight is under control.
And this is applicable for any person, right? It's not necessarily associated with Lewy body. Am I right?
No. I mean, Lewy body, the issue is hallucination. So if the hallucination part is there, then it becomes very difficult to handle. Then drugs will have to be sort of involved. I mean, you cannot take care only with non-pharmacological.
Okay. There's another question on how to handle when the patient gets scared to walk because he had a minor fall.
That is one of the most important things seen in an older adult, and that is known as the syndrome of fear of fall. It's not necessarily you have had a fall. There could be a near fall, and then after that it's secluded. The person is secluded, not wanting to walk, no confidence whatsoever. So the way I deal with it is it's obviously a one-on-one conversation with that older person. Try to see when that actual fall happens. Sometimes that fall is not even under the knowledge of the caregivers, because it's a near fall. Batane ki kya zarurat thi, kuch hua to nahi. And then they sort of with falls we always tend to connect it with results. If there was no injury, means it was not a major issue. No, that is not the thing. If it was a fall or near fall, it destroys the confidence. So we need to, I mean, I usually try to make them walk in front of me, see where the issue is. If there is actually a physical issue at all, if it's a pure confidence issue, then multiple sessions with the physiotherapist, try to give them balance exercises, try to give them that confidence that they can actually walk, because there will be a lot of counseling along with a lot of physical intervention which will be needed for building up their confidence, because this is a negative outlook, and this only increases with every sort of near thing. More secluded, ultimately socially isolating yourself, depression, and then it sort of just becomes very difficult to handle. So yeah, fear of fall is handled in this way, wherein you motivate the older person. No, things can be handled, what is the issue, and also see the cause of fall. Rule out the cause of fall, because that is, I think, very important, or near fall, because that should not happen. For example, very simple, outgrown nails, wearing loose slippers. It's not the right slipper for that particular person. So those are all things which can really sort of cause falls. The toilet height. I mean, just because a lot of older adults would not want to say, "Are kaha bole abhi? It's okay. It's been there for years together, but we are not comfortable." But then they have to. It will be a burden. He has to reconstruct. No, toilets can be raised very easily. Putting grab bars, all these things are very good for building the confidence. So if we try to modify the home also to a great extent, then also that confidence will be built, and slowly and steadily they will walk. Give them time. Do not force them to walk through. It will never happen.
Yeah. Yashri, I don't have any other questions in the chat right now, so you can carry on.
Great. Yeah, there are a couple of questions that we had from earlier. One of them was asking about how to handle stubbornness, almost OCD-like behaviors, maybe just wanting to wash the bathroom repeatedly or something. Because when the person tries to stop them from doing these things, then it leads to a lot of agitation. So how can someone handle that?
Of course, this is there has to be two ways. One is behavioral modification, which might need, of course, medicines as well. And apart from that, behavioral modification per se, try to reduce the number of times that they are doing it, and then slowly and steadily try to get them out of it. Get better people to do it. For example, say that, no, this person is already doing it, you don't need to sort of do it now. Like a lot of older people, for example, they with dementia also can be like, this is not happening the way I used to do it. So give them that confidence. You are the best, but we have better people. We have people who are doing it the best way they can, and then try to titrate is sort of this, because OCD becomes very difficult to handle, because the person gets really, you can say, aggressive, irritated if they're not doing that particular thing. So drugs have to be involved in that. But behavioral modifications, not suddenly stopping. You cannot say that you just stop. Just today you have to stop doing. No, that will not happen. Slowly and steadily, with the number of times that they're doing, try to reduce it. And ultimately, maybe if they have come to even minimal once also they are trying to do it, then try to slowly titrate it off. Because I'm saying there is no solution with confrontation. And that is the general norm of dealing with older adults. Confrontation is not going to help. It's usually, as we say, 2 steps we take, 2 steps the older adult takes, and we meet midway. That's how it should be.
And I think you've really hit the nail on the head with that example, because I mean, it's very hard sometimes for caregivers to not react in a confrontational way. I mean, as you highlighted earlier, it's really important as caregivers to acknowledge, just realize that it's not reacting to a situation that's going to help, but really thinking about how they can change their responses in ways to deal with these kind of challenges better. Another question that we have is about disorientation in the evenings, and that being related with agitation. I think something like the sundowning.
Yeah.
You can share some inputs on that.
Yeah, a lot of people have that particular sundowning, especially when sort of the light goes down and this. And so I would say for that, I wouldn't want such older adults to be in closed spaces. By closed spaces, I mean, ideally it should be, I mean, in a hospital, I make sure that they are in a bed which is close to which is actually close to the window, purely because they should know whether it's day or night. There should be a clock, actually a big one, that too, so that they actually know what time of the day it is. Then that reminiscence needs to be happening with them, wherein they actually know what they have done in the morning and what they are actually going to do, whether they have eaten, not eaten. So such things should be done so that we can actually sort of try to avoid it. A lot of times it cannot be avoided because it just happens due to the disease process. we need to also make sure it is not happening because of other causes. For example, if there is an infection, if there is pain, if there is any trigger points which are actually causing that particular, because it becomes very difficult to handle because there is no response. So once that particular thing sets in for a caregiver, it's like, no, this particular, I mean, the older adult is not even responding. So it becomes, it can either be a panic situation wherein, oh my God, what is happening? And then after some time, you realize that in the morning, they're all absolutely active and then they are doing okay. So I would say try to change certain activities also, which they usually used to do in the morning, and maybe put more stimulating activities in the evening, so that they at that particular time they actually don't go into that sundowning phase at all, and they're busy doing something else. We all, as I was saying, it's always about having a diversion, trying to divert them into something else, so that the primary disease that we're actually battling can actually take a break. I wouldn't say that it wouldn't come back, but at least we're trying to compartmentalize it, take a break, and then obviously trying to get back to normal.
Yeah, absolutely. I think these are really great tips, and thank you for sharing these. Archana, I just wanted to check, are there some more questions?
So there was a question around, the couple of questions actually. So one question is around money. And my mother does not remember how much money she has and how to deal, and tell her that she can depend on, tell her that you can depend, you have enough money to spend.
That's again, see, it's a sense of, I would always say it's a sense of self independence, and the fact that they are not dependent is always there in an older person anyways. I mean, to be very frank, anybody, I mean, you always want to have that individuality, so that will never go. Now the only way they would, if obviously they have saved enough for themselves and others, so you need to again not confront them saying that you have enough money, no need to worry about all that. You can just say that no, there you have done enough in your life to make sure that we are and you are comfortable. So I mean, that's the way we'll have to sort of deal with it, rather than saying, or I mean, things like these don't work. अरे आपको अभी काम करने की क्या जरूरत है? I mean, or why do you want to still sort of you don't need, we are there, the maid is there. Like for example, home, I would want to say the example of the homemaker again. If a homemaker has been creating brilliant dishes throughout her life, just because her age has crossed 60 doesn't mean that she should stop cooking. Just because there is another cook or person, now the role might change. For example, if physically or mentally they're not able to do, just supervising, trying to make sure that this is done that way, this is done that. As they say, there in a restaurant there is always a head chef and there is a sous chef who takes care of all the others. So that's how. So we try to remember that as caregivers, we should never try to remove a role out of an older adult's life, because they have always had a role. They were a father, they have been maybe a brother, they have been maybe a CEO or whatever in their workplace. But suddenly, if you just take out that role out of life, then it becomes very difficult for them to actually handle it as far as an individuality perspective comes. And let me be very frank, most parents do not think about money at all as far as giving it to their children or is concerned, because that is not. There have been unfortunately bad cases wherein the other way has actually happened. I would not go into the negatives, but yeah, that also sort of happens. So I would say as an older adult also, please secure yourself first and then think others. The reason being, you post retirement and you also have after that also have needs, so you need to sort of make sure that you need to tend to do that. So I think, yeah, I mean, that sort of to an extent answers what you were asking as far as the financial part and the individuality is concerned. So an older adult's individuality is very important, and it should never be lost, because then they feel lost after that, then it becomes very difficult to live.
So there is a couple of other questions. I think one of them is around understanding what my mother is feeling. I think this is the question we get asked a lot of times, that does the person with dementia have a feeling, even in advanced stage? So
I would say as a caregiver, you should believe so, because the reason being, you never want to be in the role reversal. Let me be very frank. I don't want anybody to get dementia, because that is not something you can't even think about. The fact that you just forget about keeping one pen or pencil somewhere just moves your head over. I mean, you're like, where the hell did I keep it? Where the hell did I keep it? So nobody should get it. But always maintain that they have feelings and they are feeling. That will help you in caregiving. Remember that. Don't feel that they are not acknowledging. They are doing it in that way. Whether they understanding or not is irrelevant. They might not tell you every day, oh, thank you very much for taking care of me, but they will do it in their way. And let me be very frank, if they were in your place, they would have done the same to you, and they've done it for you. I mean, when actually trying to make you bring up, they don't do it. And in either way, we shouldn't think it's as a, I don't think it's a responsibility. It's because we love our parents, they love us, that's why they do it. It's not that I mean, the legality or the societal thing where it's a responsibility that we have to take care. I don't think that's how caregivers think, and that's how parents also think. So I think that's the way you should think, purely because it helps in reducing your caregiver stress also. Or else if you keep feeling that no, there is no feeling at all, and maybe they are not able to acknowledge, and you only keep doing, so then sometimes you can get into a vicious cycle wherein you're like, am I doing it right or wrong? Or whether should I be doing it or not? Things like that. Now, of course, I would just want to dwell on one thing wherein you might actually have to decide that no, we might actually have to keep them in a elder care home. Again, that is not because you are shunning them away. That is something you should keep in mind. That is because you might be able to give them better care which you are not able to do. And abroad it's very common. I mean, in India we tend to just brand it as way because they have been taken out of the house, that's why they have been put. I mean, elder care communities are coming in India as well. I know older adults personally who have decided themselves that I don't want to live, I want to live in communities with older people, with people of my thought process, and enjoy with them, not because I don't want to live with my children. But I mean, in you know, in and around north of India also there are plenty. Down south there are plenty nana nani homes. There are a lot of examples. So that is also there. So it cannot. It's just a common misnomer that just because somebody is going into an elder care home doesn't is that there is actually a familial problem. No, there is no family problem. It's a decision that an older adult can take independently anytime. That is what I feel, autonomy that they have. So always as a caregiver, make sure that you feel that particular person has feelings, because that helps you. More than helping that person, it helps you as well. So it helps you to be positive about whatever things are going to continue, and motivates you to do whatever you are doing in a better way.
There was a question around my mother is scared of ghosts and claim that there's a ghost in the room when she's alone. I'm assuming it is hallucinations.
Again, I mean, yeah, it could be hallucination, of course, and yeah, of course, I don't think we need to argue a lot with things that we don't understand. So to be very frank, ghosts are something which are something which we can't talk much about. But if they are hallucinating, then we need to sort of treat it medically. And if it is affecting their life, because it affects not only their life but your life as well, so if we might have to give them medications for that particular thing, then we obviously sort of need to do that. But do not just brand it that are kuch nahi hai wahan pe, you're just I mean, forget about it, nothing is there, you're just thinking something. No, not that. Try to understand, listen to what it is, and then let us take that medical step. Because sometimes what happens is, just because they're saying that, we just take this decision of this, we just have to give them medication, and then, because then we don't understand what exactly is happening. Rather than understanding that, we just want to, sometimes we just want that treatment part ki nahi khatam karo, rather than understanding. So we should try to understand what exactly they want to say, and then try to go to the treatment.
Right. We have another question, which is about how do you deal with this sense of feeling invalidated when the person with dementia doesn't recognize you?
Very difficult. It's a very difficult thing because they don't. So the way you actually continue caring about that particular person is that because that is still your kin, that is still your parent, or that is still your brother, that is still your sister, whoever it is. So that feeling is very difficult, and that is why I say that the more you think about that, the more you get into a sort of a negative feeling that oh my god, now she doesn't recognize me anymore. All I can say, or he doesn't recognize, all I can say is somewhere in that particular person, whatever you're doing is being acknowledged, maybe in their way. So that is something you need to do, and this is where you need to also be able to express these feelings to whoever you are expressing, whether it's in a support group, whether it's a counselor, whether it's your friends, whether it's your family, other family, whether it's your neighbors, whoever it is, or whether it's professional. And this is also the reason that you need to get break from caregiving also. So that's why there has to be somebody else also supporting you, because ultimately it can work both ways. One is of course the fact that she's totally not knowing whom I am, and that is so sort of painful. And at the same time, I'm doing so much for a person who doesn't recognize me. So it can work sort of both ways. I would say that always think that no, it is your kin. You would love them any way they are, and that's why you're doing it. So ultimately, that's what should motivate you. It is very difficult to handle that situation, and it's very easy for me to say that no, it's very easy. It's not. And as a caregiver, you obviously know it's not. So don't be hard on yourself in that way. I would also say just try to think positive about it, that you still have had great years with them. And if it is not now, what you want to do is give them the best of time to your ability till they are there in this particular, in this particular life. So that is what you would want to do.
And I think you've really highlighted something that's very hard for caregivers, but I think it's really, really important to try and do, which is just accept what they can't change.
Exactly.
It's really, it isn't easy. And this is something that we also, help talk about a lot with caregivers. I think what you've really emphasized a lot on through this meeting has been about how it's important to kind of do this trial and error, be very creative in what you're doing as part of caregiving, particularly when it comes to managing aggressive behavior, agitation. And that is actually something which, again, you should not accept. You should really not just take this as being a part and parcel of, dementia. This is one behavior that needs to be dealt with. It's not something that one should ignore, be it through the non-pharmacological methods, or if where medication is required through that. But this is something that's absolutely essential to address. Because otherwise it could potentially lead to the patient harming themselves or others. And you've really, just to summarize, you've highlighted a number of ways in which caregivers can start to think about what's really underlying that aggressive behavior. You mentioned the importance of looking for triggers, which is so important, trying to understand, is there something that the patient needs, which they're unable to, really communicate and ask for? Is there something in the environment which is a trigger? Is it something in the people around them which is causing it as a trigger? So what is the triggers? What's the pattern? These are things that caregivers need to try and really take a step back, think about, particularly if there's a lot of agitation and aggression. And the other things, we spoke about so many other issues that people listening in and who've joined us have raised. But yeah, some things we may work with, some things, we may see changes in, we may see changes up to a certain point. But yeah, we can't reverse everything. You may not be very successful with certain things, so you may just have to accept them. I mean, we spoke about the food and feeding in small quantities. This is something which a lot of carers struggle with. It's so frustrating, and I think that's something which many carers may just have to accept as a change, and one of those frustrating things that's that's there. And I think you really highlighted another aspect, which is very important about, the identity of the person, making sure that they still have some sort of a role in the family or in whatever way that's possible, giving them that meaning. And ensure that that's really an important part of keeping that the dignity of the patient. And without doubt, I think one thing you've really emphasized again and again is to look at the whole caregiving process just from a slightly different lens. Yes, there is a role reversal. Yes, there are frustrating moments. It's very difficult to be a caregiver. There are a lot of challenges, but to kind of not do caregiving because and feel guilty about what's not being done, but to really look at what you're giving as a caregiver and value that. Because somewhere the patient is valuing that. It's just that they're not able to express it, because unfortunately that's what the illness does. It really takes away the ability to communicate effectively, to remember even what a person is doing for them. And it's very, very unfortunate, but that's just what the illness is. So thank you very much for joining us today and sharing all these wonderful insights. I'm sure the people who are listening in have really gained a lot, and thank you to all the participants for joining in and sharing your experiences. I think one of the reasons why we conduct these support group programs on a regular basis is because it's really important to learn from each other, to really see how we're dealing with these various challenging behaviors. It's really important to share ideas and ways to kind of add to that bucket of creative tools that you might need to dip into to manage the various challenges. So before we close, I'd just like to mention that we are having a memory screening camp on 18th. That's next Friday in the day, and do watch out for more details on that, which we will be sharing. And we'll be having another talk on really what are some of the lessons that we've learned from 2020. It's been a pretty unbelievable year. It's taught us a lot in many ways, and we'll be talking about some of these aspects on the 18th. And we'll also be having our next support group meeting on the 15th of January, where we'll be joined by Dr. Vijay. He's a geriatric psychiatrist from in Bangalore, and he'll be joining us for the support group meeting on January 15th. So we'll be sharing more details about that. But before we close, Dr. Prem, any final thoughts that you would like to share?
Yeah, I would say just keywords. I think one is expectations. You need to know how much the disease can go bad and what state it is. One is acceptance. Try to accept the reality where we are as far as the disease is concerned, and then caregiving obviously becomes easier. And third, as you had already mentioned, and I had mentioned earlier, is identity. And identity of any person is important. And I mean identity of both. I mean identity of the older adult and the identity of the caregiver itself. Sometimes caregiving can be so tedious that you forget yourself. So your identity goes. So that is also something that you need to preserve, because you will be taking care of that particular person, but you will have other responsibilities as well. You also have a life to live on too. So do not forget that particular identity as well. So I think these are the three keywords. And fourth is, if at any point somebody has memory issues, get yourself tested. Why? Not everything is irreversible or is Alzheimer's. There are two things to it. One is it will help you to take out that fear that you actually have a memory problem. And second is early detection in any disease is always good. So if you are detected earlier, we might actually be able to help you even more, and we can put you into a plateau phase, or it might not get worsen ever. So don't have that. The word is, in Hindi we say jhujak. It's like you don't want to do it, because if something is discovered, remember, if something is discovered at an earlier time, it's always better. The later, it's actually more worse. So try to, and also as a caregiver, and as of course Samvedna does it, always try to support those who forget, and do not forget those who support them as well. So take care of yourselves also, because that's very important to take care of them. Thank you. I mean, that's sort of where I would want to end.
Thank you, Dr. Prem. On behalf of Samvedna, I would like to extend a very hearty thank you to you. And
thanks for having me.
For your thoughts, and I could, through your conversation, I could see that you're very passionate about this area, and you know, your advice was very practical, and I hope we all can take some of it and apply it to our families, whoever is a carer here. And there's a last question which I'm almost winding up, but it was a tricky one, so I thought I'll just take it. Somebody is asking, whom should we see for dementia, a psychiatrist or a neurologist? I think you should go and see a geriatrician.
Yeah, that's what I was going to say.
So
I would say it's a multidisciplinary intervention which is always needed. All of them have limitations. All of them have their strengths. And that's why we try to focus on, I mean, that's what elder care is about. Try to give multitudes so that interdisciplinary people can give you better care. So a holistic care sometimes will not be always possible by one person. Right. So many people might have to be involved. But yeah, I agree with ma'am. The geriatrician comes first.
Yeah, and that's what we try to do that with our patients. We advise them with a holistic care, which includes a doctor, a psychologist, and then the specialist and the attendant, you know. So
I think everybody has their role to play. That's what I feel.
So everybody has a role to play. Family and friends who visit you once in a while also have a role to play, to be sensitive to the care.
Absolutely. I think the part of the care team includes the patient and the caregiver. So that's what the team is about. Yeah.
Right. So thanks a lot for your time today. Thanks, Jayashree, for taking us through this. And Samvedna is there in case anybody has any questions. Now we are also supporting, we are able to provide our services online in case anybody is watching this from any other city. In terms of the kind of cognitive stimulation services we provide for early dementia, and also counseling for the caregiver stress-related issues, and generally to understand the disease and get your queries answered. We are here to support you. So you can always write in to us at contact@samvednacare.com. And thanks everyone. Have a good evening and a good weekend ahead. Thank you, doctor.
Thank you. Good evening. Bye-bye.
Yeah. Can you hear? Am I audible, madam?
Yes, sir.
Okay. My name is S.K. Chawla, and sorry for coming a little late, but and I will take maybe 2 minutes, maximum 1.5 to 2 minutes. I know that I have been a caregiver, as well as now I am feeling that I am myself coming to that stage. I'm already 83 plus. That certain signs of which are the earlier parts of the disease normally, if it is a disease in me, I don't know. But the point is that I have got number of problems in my I'm a heart patient. I am also diabetic. Well, it's okay. I have arthritis, and I have been a very active professional in my life. So this is my person, and in my own life, I have lost 2 very close relatives in the past. So this is my overall build, and only to get rid of those unpleasant memories, I became a member of the Indian Cancer Society, and I was regularly visiting the hospitals and spending time with the patients as a caregiver. But I'm not a professional caregiver as such. I'm an emotional caregiver. Anyway, now because of my other medical condition, I am not able to kind of devote time on that thing. I'm not able to reach the hospital also. Now my problem and difficulty is that I'm being single in the family. only I am the eldest in the family, and my family are always very supportive. Everybody is short of time. So I feel isolated, and I tend to go back to my old memory. And in some cases, I feel very depressed. And I have got number of hobbies. I'm quite spiritualistic myself. I keep on watching things. I keep on reading things. But there are severe, should I say, mood swings. And due to these mood swings, I feel somewhat guilty.
ये कौन है?
So I'm sorry, can you just check? I think you've gone on mute. Could I request you to just unmute yourself? I'm unable to hear you.
Is it okay?
Yes, thank you.
Sorry, it was a very long description. My fault.
Yes, I just missed the last part. If you can just ask your question briefly. I do understand that you were involved with a lot of caregiving previously. Can you just ask your question briefly?
Should I reply to this, or you are answering my question?
No, can you just ask your question briefly?
My only question is, what should I do? A, to identify whether the disease has started as such, or B, do you have any other suggestion to control my mood swings, basically?
Sure. No, thank you. I think these are really important questions, and thank you for asking this. One of the things I mentioned earlier is we're actually having a memory screening camp, which is next Friday. On the 18th, you will receive, if you've registered for today's support group meeting, everybody will receive details about how to register for the memory screening camp. This will be an online memory screening camp, and I think that would be a good space to talk one-on-one with a specialist and share your concerns. We'll also do a screening and be able to give you more specific advice during that time.
On 18th, is it?
On 18th.
So
So
will
we'll
you
make
give
sure
me another notice for that? Will there be?
We'll get in touch with you for that.
Okay, thank you very much. Thank you.
My pleasure.
Bye.
So thank you very much for joining us today, and I think it's been a really great discussion. Thank you very much.
Thank you.
Thank you.